We now will go to the next panel, and the first presentation is from the Ontario Association of Cardiologists.
Okay, thank you very much. I'm Dr. Richard Davies, a cardiologist and professor of medicine at the University of Ottawa Heart Institute and deputy chair of the OMA section of cardiology. With me today are Drs. Michael Hartleib, who's a cardiologist at the Peterborough Regional Health Centre and secretary of the OMA cardiology section, and Dr. John Parker, a cardiologist and professor of medicine at the University Health Network in Toronto and the chair of the OMA cardiology section. All three of us are board members of the Ontario Association of Cardiologists, which is an organization that represents both academic and community-based cardiologists across the province. We're very pleased to be here with you today to share the thoughts and recommendations of the section of cardiology and our association regarding the 2022 Ontario budget. As a background, good healthcare delivery depends crucially on an underlying economic infrastructure that supports and encourages both best medical practices and innovation. And the work of your committee is therefore crucial for the ongoing excellence of healthcare in Ontario, and we'd like to offer the enthusiastic support of our section and our specialty to accomplish this. Over the past 2 years, the pandemic has forced Ontario's physicians to adjust the ways in which we deliver healthcare, both for patients with COVID and for those with other chronic conditions that need to be looked after. On this background, we'd like to focus on 3 areas of need that we think should be given a high priority in the upcoming budget. First, these are the need for the ongoing development and support of virtual healthcare to serve Ontario's patients beyond the pandemic. The pandemic has taught us this is a very useful modality that can be combined with other things. The second is the need to provide Ontario's congestive heart failure patients with better access to specialty-based care. This is very important as heart failure is the chronic disease of cardiology and one of the most important diagnoses for healthcare costs and healthcare benefits. Finally, there's the need to support an increasingly fragile and vulnerable infrastructure for specialist outpatient care in Ontario. To discuss these priorities further, I'd like to pass the microphone now to Drs. Hartleib and Dr. Parker.
So thanks, Dr. Davies, and thank you all for allowing us to speak this afternoon. I'm going to speak quickly about virtual care and then turn to heart failure. So as many of you are aware, the pandemic has necessitated and accelerated our adoption of virtual care and allowed us to discover opportunities, risks, and benefits for the healthcare system. In March of 2020, the Ontario government introduced virtual fee codes on a temporary basis for payment of physicians for providing virtual care to patients. These codes have been essential in maintaining access to medical care during the pandemic. And I can tell you, for example, many of my patients simply declined to attend in-person care out of pandemic fear. More than this, however, I work in a large and geographically diverse region in Ontario with a very high proportion of elderly patients. Many of my patients need to travel long distances for inpatient visits. They're a challenge to arrange transport or express environmental concerns about driving. And patients, in addition, often have challenges taking time off work or simply prefer virtual visits, particularly for simple problems. And let's be honest, we live in Canada where yesterday's weather event does occur. And despite the fact that I couldn't get out of my driveway and actually had to shut down the entirety of my clinic, I was actually still able to see the majority of my, or at least speak to the majority of my clinic patients yesterday, which previous to March 2020 wouldn't have been able to do so. You may have heard concerns about access during the pandemic, although in short, because of virtual codes, we've never closed our doors during the pandemic. We've continued to serve our community in the region, and we're able to accommodate patient preference. Importantly, those who need to be seen are seen. Those who want to be seen are seen. And those who prefer virtual care where medically safe are accommodated. We can successfully provide virtual care because we continue to see our patients in person. Virtual care codes are set to expire in September of 2022. And of course, on this basis, we're urging the government to make virtual fee codes permanent and work with our organization and other provincial regulatory bodies to revise the schedule of benefits to reflect, well, our new realities. I'm going to take just a second to turn to the specific disease entity of congestive heart failure. As Dr. Davies mentioned, congestive heart failure is one of the number one causes of admission and readmission to the hospital, carries significant morbidity. What most people don't understand is that in many cases it has a higher mortality rate than many cancers. And this is why these very complex patients account for such a significant cost to the system. And unfortunately, because more Canadians are surviving cardiovascular disease, more are developing heart failure. The incidence and costs of this disease continue to rise. Cardiologists trained for years to learn how to manage congestive heart failure. The complexity of managing this chronic disease was in the past recognized by appropriate remuneration to physicians. In April of 2015, this complex disease code was removed and payment adjusted such that cardiologists no longer had access to this fee code, while at the same time, less well-trained physicians continued to receive extra payment. To be clear, at this time, those with less training are currently being paid more than cardiologists to manage the same patient. Over the same time period, appropriate guideline recommended care has only become more complex, while those specialized and rigorously trained continue to be disincentivized. I'm going to turn this over to Dr. Parker to further address congestive heart failure management.
Hi there, John Parker. I'm a cardiologist at
If I could
downtown.
just stop you for a moment, I would like the previous speaker to identify their name. They didn't start with introducing themselves.
Many apologies. Mike Hartleib, I'm a cardiologist in Peterborough Regional Health Center.
Thank you very much. Okay, now we'll start, and we'll put an extra minute on it. Thank you very much, Doctor.
Hi, I'm John Parker. I'm a cardiologist in downtown Toronto at Mount Sinai and University Health Network. I came to Canada after training in the U.S. I am Canadian by birth in 1992, so I've been here quite a while. I first will address heart failure management in the province. As mentioned by my colleagues, heart failure is actually the most common reason for an adult greater than 50 years of age to be admitted to hospital. And heart failure is a huge cause of mortality and morbidity in the community. The management of these patients, particularly the more and more complex drug regimens proven to be effective, requires specialty input both to begin and maintain therapy. A number of excellent research programs, actually many of them carried out in Ontario, have documented that early follow-up by a cardiologist after discharge from hospital improves outcome, reducing the need for repeat hospitalization while greatly improving quality of life. Unfortunately, to date, despite many attempts, proper funding to allow organization of specialty follow-up with cardiologists has not come forward from the ministry. The ministry has launched efforts to address this problem, but the focus has been on primarily primary care, family physician management. While the latter is clearly important, there needs to be more emphasis on developing a program where all patients with a diagnosis of heart failure in the province of Ontario.
We do have to stop there, and we'll have to start what the question is, and hopefully we can get all that information in the answers to the questions. And the first round will be started by independent, MPP Samard.
Thank you, Chair, and I wanted to thank all three groups presenting. I have questions for all three groups, but for the first round, I believe I will go with the Ontario Association of Cardiologists. I'm in a rural riding with many small towns, and so access to any type of healthcare, specialized, is at least a 40-minute drive, and that's on the highway, right? And it requires often for people to have rides from a family member or whomever, seniors, but also people that are sick, right? And so the virtual is extremely important. And I always wondered why, it took a pandemic to start doing that. But whatever it takes, at least we're there now. And I wanted to let you elaborate if you want, if there's more to say on the virtual healthcare, the adjustments that need to be made. I know you spoke about the virtual care fee code that was temporary, but are there any other tweaks or supports, adjustments that need to be made to have a better infrastructure for virtual care? Because I believe in my area and many other areas in Eastern Ontario and across the province, this is super important because It's time saving. It's a security issue for many seniors also who can't drive. And I think this just makes for certain services, obviously, but it just makes everything easier for many people. And so I think we should be doing everything we can to support you in any way to do those virtual consultations or visits.
Davies, first, well, I'll just say we agree with you completely. We've learned with the pandemic how useful virtual care can be. It should be combined with the ability for in-person care. Sometimes we need to do a physical exam, but certainly not on every visit. Virtual care also allows us to be much more efficient. And I think you've stated the case very well. This is exactly why we think this is important and something that needs to be carried forward, because we're very sensitive to how hard it is for patients to come in. When they need to, but when they don't, they really shouldn't have to. So maybe Dr. Hartleib or Parker, any comments further?
No, other than Amanda, I completely agree with every one of your comments. I might, if it's okay with you, turn it over to Dr. Parker. You asked a really good question about what other infrastructure might be necessary to support this. And I think I'll turn it over to Dr. Parker on that, who has some thoughts on this, if that's okay.
Yeah, well, I certainly agree. And I've been very involved in a number of groups looking at care in remote communities, and your story is really harmonious with many communities where people have to go a long way and they have trouble accessing care. And I think that we need to establish with the ministry mechanisms for not only doing virtual visits, but allowing ease of access of remote patients to specialty care, not only in cardiology, but to other subspecialties. Mm-hmm. It is correct that some patients will need to be seen in our field at some point and at times, but actually a lot of follow-up relating to testing results can be done remotely and effectively.
Exactly. And I was also thinking, even post-pandemic, when I'm sitting at the doctor's office waiting for my appointment or any, healthcare setting, and maybe that doesn't apply to the cardiologist specifically, but you're in a healthcare setting, there's risks associated to that as well, being somewhere where other people are sick, right? And I know that doesn't apply to you, but in other settings, I do believe that there's an importance to that. So if there's anything that you also want to submit after, this is not your only opportunity, but if you think of needs and supports that you would need for virtual, to assist in the virtual care.
So I do want to pick up a little bit with the Ontario Association of Cardiologists. I thank you for your presentation. You've made a number of, I couldn't write fast enough, actually, to be honest with you, to keep track of. Dr. Hartleib was speaking, I believe it was him going through that list, and it was a little hard for me to keep up and listen at the same time. But you're raising a lot of really important issues, and I just want to thank you for doing that. But also, I'm assuming, quite frankly, you've got a significant written submission prepared, because I know you can't do that in the 7 minutes that's allocated to you in this forum. But those things that you've been asking for, I'm sure that you've forwarded them through SCOFIA, but also hopefully directly to the Ministry of Health, because this being a critical point. And to MPP Simard's point, where I live in Barry's Bay, we're talking a minimum on a good day of 2 hours to Ottawa, and more like 4 hours to Toronto. So Ottawa is certainly the tertiary care center for people in my riding, but some of us, because it's such a big riding, many of us live much farther away. So totally understand the suggestion about more virtual care. And if you want to expand on any of those issues that you brought forward, I'll give you this opportunity with the little time we have left.
The only comment I would make, so we actually see patients from Barry's Bay and Peterborough, so I'll throw that out there. But the only comment I would make is that there is support for infrastructure, and that infrastructure is critical. You can't provide virtual care if you are not at the same time prepared to
1
provide
minute.
in-person care. Is that time or is that?
1 minute left.
Oh, 1 minute. Okay, okay. So what I want to say is that it's yes, we've got to have virtual care, but we also need support for the infrastructure whereby we can continue to provide inpatient care. And that's at risk because what people maybe don't get is that the majority of patient care in Ontario occurs outside the walls of the hospital, 80 to 90% of the time. And the people who pay for that are the physicians. Our overhead actually continues to rise, and the support for that overhead, the bricks and mortar, the place where people can come when they need to come, is threatened. And so what we're looking for, and we're open to novel suggestions to support the infrastructure whereby 80 to 90% of the care that patients in Ontario receive can be supported and is no longer threatened. Right now, it's on a shoestring and it's on a knife edge.
Thank you very much. That does conclude the time for that presentation. Now we'll go to the official opposition. And MPP Arthur.
Good afternoon, everyone, and thank you so much for wrapping up the day with the last presentation. You know it's been a long day on committee when your headphones run out of juice. The last one, you have to run and find another pair. I'm going to start briefly with the cardiologists. A couple of kind of questions. Your virtual care codes, where are they for cost equivalency to similar care in person? Is there a difference there?
Well, actually, there's not. The fee codes that we use are meant to parallel. So there's essentially one K code that we use, and then we've essentially instructed to essentially bill the number that makes it appropriate. Yeah. So essentially, a consultation is the same. I'd also comment, though, that the overall level of those codes haven't literally changed in decades, and they're about 2.5 times lower than are currently recommended by the OMA for the equivalent service, and we all have to vastly supplement the overhead with money coming from other places because simply it is not possible to set up a clinic and see patients and make that work.
You beat me to it. That's where I was going with that line of questioning. But thank you very much for that. On the virtual healthcare and where it can be appropriately applied, would any of you care to comment on the role that technology will likely play in virtual care in the future and the ability for all sorts of monitoring devices with patients and how a combination of that could further increase care if it was expanded in Ontario? Yes.
I was just going to suggest this might go best to John, who actually has a much better, more broader experience in this. So, John, I turn it to you, maybe.
Yeah, thanks. Well, I think it will take something it'll be something that takes time to develop. I think we view it as a generational issue. So I have hundreds of patients in their 80s that really aren't comfortable with even using a computer interface, and it works quite well on the phone. We do have eHealth Ontario where we can work with setup appointments. It's a little bit onerous in terms of the timing. To another part of your question is whether remote monitoring will help patients. And yes, we should be able to, if we had the right infrastructure, to allow a patient who needs a certain test some tests can be done remotely with little in the way of infrastructure, but just need a mechanism to say this patient needs, for instance, a rhythm monitoring device. It can be applied locally, and then the results can be interpreted and the patient can be contacted and seen if necessary. So I would say that this goes in line with what I was trying to describe as the need for heart failure support across the province. We need to work out mechanisms where patients can receive appropriate care, but minimize the problems of distance and actually, frankly, the lack of care many patients have simply because of distance and the problem with being able to reach out to a community and organize testing for a patient and avoid them having to travel 2 hours to get a simple device hooked on, which takes 2 minutes.
Yeah.
There are many examples I could give, but that's the general tone of it. To do that, we really need to have a structure in place where there's cooperation between the communities and not necessarily academic centers, but centers such as Dr. Hartleib's, which is a very sophisticated cardiac care program, but can be hundreds of kilometers away from the patients they serve.